Welcome to another podcast episode by Impact Medicom. In today's podcast, we talk about the opioid epidemic and the unique position that pharmacists find themselves in to help reduce the number of opioid-related deaths. We are joined by Dr. Ross Tsuyuki and Mark Barnes, who are co-authors on the first ever Canadian guidelines for naloxone prescribing by pharmacists. The development of the guidelines was managed by us at Impact Medicom with a steering committee of pharmacists from across Canada. Today's episode is hosted by myself, Anna Christofides, owner of Impact Medicom. Hope you enjoy it. Welcome, everyone, and thanks for joining me today for this podcast episode. So let's start by going around and introducing ourselves. I was wondering if you could maybe talk a little bit about your involvement in the fight against the opioid epidemic and what drew you to the area. Dr. Tsuyuki, would you like to start?
Sure. My name is Ross Tsuyuki. I'm a pharmacist, and my day job is I'm a professor in the Faculty of Medicine at the University of Alberta, and I'm chair of the Department of Pharmacology. My research interests are really in public health, and in particular, the role that pharmacists can play in public health. So, the important issues like cardiovascular disease and now, the opioid epidemic. And I also do research, pharmacy practice research in this area. I guess the other hat that I wear is I'm editor-in-chief of the Canadian Pharmacist Journal, which is relevant to, some of the things that we'll be talking about.
Great. Hey, thanks so much, Ross. And yourself, Mark?
Hi, my name is Mark Barnes. I'm a community-based pharmacist in Ottawa. We work in, primary practice or inner-city addiction-focused pharmacies. So we own the companies RespectRx Pharmacy and in partnership with Recovery Care. And we are, boots to the ground type of practice where we have access to about 2,500 people who are addicted to opioids. In Eastern Ontario, we have locations in Cornwall. We have 4 in Ottawa and soon to be 1 in Kingston. So we are kind of boots to the ground addiction treatment professionals. I'm sort of got started in the whole opioid crisis and this, environment through own personal experience. We owned community pharmacies long before RespectRx. And I actually had the misfortune of dispensing a fentanyl, cancer pain patch to a dying patient. And they sold that patch to a 19-year-old man who overdosed and died. So that was the first fentanyl overdose in our community. And at that point, I developed the Patch for Patch Return program for Ontario, with some help from folks in North Bay and through Vic Fideli. And now that's Ontario law. And since then, we've been kind of trying to fight the crisis as best we can, and also reduce some of the marginalization and stigma around addiction.
So Mark's the real pharmacist.
Wouldn't say that.
That's really great. No, thank you both for sharing your backgrounds. That's really helpful. So I guess I wanted to get into a little bit of understanding. I mean, we hear about the opioid epidemic, but really, how big of a problem is it? How big is it? I don't know if Mark, you wanted to talk a little bit about that first.
Well, really, it's a current environment. It's interesting. We do have a real problem, and really, I always present it as Canada really is at the epicenter of the opioid crisis in the world. I mean, one of them. We consume the second most amount of opioids, I think, per capita in the world. And if you look at the sheer number of opioid prescriptions that the Canadians are taking, let alone the illicit opioids on the street, and then, the cross-contaminant of opioids and other street drugs, we are in an absolute crisis. If you think about it, in 2018, we lost over 4,400 people to an opioid overdose, death, with roughly 1 every 2 hours. For car accident victims, if you want to put it in perspective, we lose the life of a car accident victim 1 every 4 hours. So ultimately, you're twice as likely to go to a funeral for someone who died of an opioid overdose than a car accident. When you keep that in perspective and think about the sheer number of the amount of money we spend on seatbelt safety and road salt and speed limits and new highways, I mean, they're all harm reduction techniques. Well, where's all the approaches in addiction?
Wow, that's definitely puts it in perspective for sure. It's quite something. How have those numbers changed with COVID? Have they gone up? Have they gone down?
Wow.
Well, first of all, I mean, just interesting enough, in 2019, Canada actually did a fairly decent job of, we all know this term now, flattening the curve with regards to opioid overdose. We kind of lowered the deaths to 3,823. We are making headway. And how do we make headway? Through massive amounts of naloxone distribution, education programs just like this, and really, every level of government being committed to this opioid crisis, whether it be the Health Canada and even buying marketing during Hockey Night in Canada, can you believe? And provincial governments with their naloxone programs. And so really it's wonderful. We slowed it, and that's awesome. And I'm a passionate advocate for naloxone use. I mean, we have the highest naloxone distribution in Ontario at 38.1 per opiate harm. It's awesome. However, we are only reaching here in Ottawa, and for the best, only reaching about 1 every 4 opioid deaths according to our corner data. So it's bad. It's real bad. And then with COVID and the current environment, with the introduction of fear, anxiety, social distancing, and using drugs alone, as well as money with CERB, we are expecting a 25 to 35% increase in the number of opioid deaths in 2020. So we're back up over 18, and we're probably going to be close to the 5,000 range.
Wow, that's quite shocking.
Yeah. So this seems like the analogy of pouring gasoline on a fire seems appropriate here. It's pretty scary.
That's for sure. So maybe I don't know, Ross, do you want to talk a little bit about what naloxone is, just for our listeners that may not be aware of that?
Sure.
Of naloxone.
Yeah. Well, so naloxone, there's an opioid receptor, and naloxone competes for that receptor, and so essentially it's the antidote to an opioid poisoning, and it works very quickly, so that is the antidote, to the problem. So having that around, is kind of your, I guess, the equivalent of a defibrillator, on the wall. And we have defibrillators on the wall in, every public place, but we don't have naloxone, right? We have airbags in cars. We don't have naloxone, widely available, at least to, people that need it.
Yeah, that's it's quite amazing that's not the case. And what are maybe some of the barriers to that? Why do you think that is? Either of you, feel free to jump in. Mm-hmm.
Well, Mark, I'm sure you got a big long list of them. Well, the stigma is, start with that, right? People don't like the stigma associated with opioid use, right? And so why would I need this antidote? That's one of the things, definitely. And Mark.
Yeah, so I mean, stigma is the biggest one. I think, Ross, you're right. And then even among our profession as pharmacists, I think you and I are both proud pharmacists. But let's face it, even in our own backyard, in the college, in our own college, among our own profession, we got a lot of work to do. Like, we got to kind of open the eyes and ears to pharmacists to say, listen, you know what? Opiate use disorder is not a character flaw, a moral insufficiency. It really is a mental health disorder. Unfortunately, because it's a relapsing condition, there will be drug use. There will be overdoses. We have a very toxic drug supply in Canada. There's tons of opioids around. People will overdose. We need to have naloxone around. We need to support these folks till they get better, which may take 15 years. So how are we going to do that? We're going to do that with wide access to naloxone, asking patients to have it, using it as a part of their tool. I like to equate naloxone as the EpiPen for opioids.
Absolutely.
It's a nasal spray in some places and an injection in others. And it works the same way, like an EpiPen. It doesn't remove peanuts in the body. It doesn't remove the opioids, but it can provide valuable seconds and minutes to get those paramedics there, to keep them alive, keep them breathing, to give them another shot at recovery. And that's what we need to do for a humanity standpoint. And if you don't even believe the anti-stigma campaign, and you're not a big fan of supporting people with drug use and accepting that it is a mental health disorder, then think of your dollars and cents. It is cheaper to give everyone naloxone in Canada than to treat an overdose that costs 17 to 20 grand.
Wow. Yeah, that's a big difference. Go ahead, Ross, sorry.
Well, I know, I mean, so well stated. I mean, there's no stigma associated with an EpiPen.
Right. Right.
Right. Nobody thinks twice about being offered an EpiPen, and yet there's all this stigma associated with naloxone. Incredible.
Yeah, people think because you carry a naloxone kit or ask for a naloxone kit that you're a drug user.
Yeah.
You're not. You're a superhero. You cannot even use naloxone on yourself because you're actually unconscious in an overdose. Yeah. You're ready for surgery, right? You're actually becoming a superhero by carrying one. And that's what you don't understand. You're becoming a superhero first responder to help somebody else in this crisis.
Yeah. It's a lot cheaper than carrying around a defibrillator.
Yes, you're right.
It's a little easier to carry too.
Yeah. For sure. All really good points. And so what is the pharmacist role then? Both of you as pharmacists, what are your roles in this fight?
Well, Mark, do you want to start?
Sure. I guess my role is awareness, right? So, pharmacists ultimately, we're not, first of all, let's get this out on this podcast. We are not pill counters. Please, for the love of God, stop putting us on TV. Okay, we are actually healthcare professionals, and mainly what we are, we're educators, right? So we like to educate patients on drugs, how to use them properly, what to watch out for. We communicate with other health professionals about, hey, this interacts with that. So now we have the responsibility and the obligation during this opioid crisis, and being the gatekeepers of opioids, that we have to educate our patients about the risks. We have to screen for the high-risk addiction client. And then we have to educate practitioners, physicians, nurse practitioners who are prescribing that we should also be adding naloxone to that prescription to make sure that if there's cases of an accidental ingestion or too much or diversion, that there's a naloxone kit in the community to help prevent that.
Yeah, and absolutely. Is it really? Sorry, go ahead,
Bob, sorry. No, absolutely. We in a way, we're like the ultimate public health professional, right? Because we're so accessible. I mean, how many public health units are there, right? They do good work, but they're, a few in the city, maybe, right? And nobody goes to them. Whereas how many pharmacies are there? So we're kind of the ultimate public health professional. And I think, just to build on what Mark was saying, the statistics are that between a quarter and a third of overdoses are occurring with prescription opioids, right? And the only place you can get a prescription opioid is through a pharmacy. So right off the bat, a quarter to a third of the ones we could intervene on, right? That's not to mention all the other ones, right? But that's huge, right? From a public health point of view.
So well said, Ross. And the thing is too, is that, okay, so public health, well, first of all, pharmacies are open late and on weekends, okay? Public health is not usually, no disrespect. And I'm on the overdose task force with the Ottawa Public Health. They're one of my biggest partners, and we do a ton of great work together in our community. That being said, COVID has hit them hard. Resources are diverted right now. They need everybody possible, and they're hiring back retired nurses to kind of just deal with this absolute pandemic. But during this pandemic, as we just mentioned, the epidemic of opioid use is still growing underneath it. So now it's our turn to step up as public health professionals, like Ross said, and get out in the community. Remember, going to a pharmacy or going to a public health nurse, people find very stigmatizing potentially and or triggering. Listen, maybe their addiction started at the pharmacy. They don't want to go back in there. So we have to support them through not just the opioid users and people who are using opioids, but their friends, their families, and people who live in high-risk communities. It has to start extending out past people who are just getting opioids.
Well, and that's actually that's a really good point too, because I would think that there's less stigma in going to a pharmacy than there is to go to public health. So again, it speaks to that accessibility thing, which is, doesn't matter what the intervention is, doesn't matter what the disease state is, accessibility to where the people actually are is key. And, you could be talking about hypertension, you could be talking about all kinds of things. Accessibility, as we've defined it, is so important. Because if you don't have that, doesn't matter if you're a great clinician. It doesn't matter,
Right.
because if people can't get to you, or there's all these barriers, it's kind of irrelevant, right? And so that's what we have going for us as pharmacists is the accessibility.
That makes a lot of sense. So thinking about the pharmacist's role further, I know that there was a recent document that was created for pharmacists. Ross, did you want to talk a little bit about the background to that and where it led?
Sure. Well, I guess there's a couple of things that we did, but essentially we had a meeting of experts in the field around pharmacy and the opioid crisis, and so that was a really informative meeting. As part of the homework for that meeting, my master's student Randy So had been working on an evaluation of kind of the barriers to naloxone use through pharmacies, because I knew that that's what we were going to be talking about. And so he did a coast to coast review of that, and I know, Mark, you helped us a lot with it, and it was pretty eye-opening that only about 50% of the provinces even have pharmacies involved, which makes zero sense to me. And so that was one of the eye-opening things. And then there's great disparity between whether pharmacists are if it's even available, for one thing, and then whether pharmacists are even paid to do it. And that's not even if you're interested in trying to address this crisis, in a lot of provinces, pharmacists don't even have the tools to be able to do that. And so that's the first thing that we had talked about, then we started to talk about who should pharmacists give naloxone to. We went through a big discussion about the risk factors. We went through all of those kinds of barriers that might happen, and we talked about different sorts of approaches. We talked a lot about the stigma, and what we decided was that the best thing we could do is provide a guidance document for pharmacists. So we looked to see if anybody else had done this, and amazingly, nobody had done this, pharmacy or not, and so there were no guidance documents on naloxone use. So we decided, well, we've got all these smart people in the room. Why don't we come up with our own evidence-based guidelines document? So I think we're the first ones actually to come up with a document like this, and it's directed towards pharmacists in particular. And the bottom line from our guidance, our guidelines document, is that we decided that the best approach was that all patients prescribed an opioid should receive a take-home naloxone kit with appropriate counseling from their pharmacist and follow-up with them. And we went through some details on what is the language you should use, and here, you need this, that's not going to work. That's where some of the ideas about calling it your EpiPen for opioids, those kind of things that come from very experienced experts, those are the kinds of tools that people need. You need a little script to say, you don't want to say, well, you look kind of shady, so you need a naloxone kit. You want to say, look, I give this to everyone because of the potential harms.
Well, that's great. And so this document really, as you said, is the first guideline on this topic for pharmacists that's directed towards pharmacists. Is that correct? Yeah.
Yes. As far as I know. I don't know, Mark, you've never seen anything.
There's been a couple little snippets in pharmacy magazines about little things we've developed in the past about, hey, just like a little piece of information, but not an evidence-based document like this, Ross. It's pretty wonderful. So. Yeah,
and so where would, if you're a pharmacist and you want to access this this guideline, where would you go to get that?
So it's open access, so it doesn't matter if you're a subscriber or not, but it's the Canadian Pharmacist Journal. So it's cpjournal.ca, and then you'll see it there. And so as I said, it's open access. Anybody can download that. And hopefully in the future, we're going to develop some tools to go along with that. But for now, the document is available free of charge. And that's a starting point. But what we got to do is we got to go a step further now and get it out to people, which is, of course, what we're doing today, but also, to give people the tools to be able to do this. And, we're even thinking in the future, we should be studying this. We should be keeping some statistics and seeing if we can't allow, give pharmacists the opportunity to show how they can improve these, this issue.
Ross is too nice. The reason why I say that
I am not.
The reason why is that we should give pharmacists the opportunity to make the decision to do it. Whereas my vote on the panel was, let's make this a standard of practice at every college so that they have to do it. Obviously I know we can't do that yet. And, that needs a buy-in from a whole level of healthcare, but certainly that's how passionate I feel about this document. It's a fantastic start because we haven't been talking about this before. And pharmacists need to be aware that they need to be doing this. And I believe it's their professional responsibility. And I would like that our colleges would adopt that attitude and make it a standard practice, but we'll see how that goes. But we're not stopping here.
Yeah, absolutely. And, actually, you were the one that brought up that idea. Well, let's make it the law, actually, a standard practice. And I actually spoke to a couple of registrars. I don't know if I told you this, Mark, but
no.
I spoke to a couple of registrars about this, and they said, that's a very good idea, but we don't, we tell you things you can't do. We don't make laws about what you need to do, However, I think everyone I spoke to agreed, and they said, no, it should be, a pharmacist practice should be proactive and it should be in the patient's best interest, right? And this is absolutely in the patient's best interest. So it does fit very well. It's just that they are not really set up to say, if this, you must do this, right? But it is a standard of practice. And so, at least we have that sort of backing. What we need to do is, it's almost a cultural change. We need to say that it is unacceptable not to do this. And there's lots of things in pharmacy where we need to change that culture.
Right.
You have a responsibility for this patient. And in fact, I could see Mark saying, you dispense an opioid, you're responsible for it. You better damn well make sure that they get a naloxone kit.
I kind of do. So in Ottawa, here's an example. During the whole batch for patch with fentanyl patch attached for perm program that's now law in Ontario, that went through Royal Assent to the government and then back down to the colleges. There wasn't buy-in in Ottawa. In the pharmacy, I was in Ottawa doing it. I was like, wicked, this is awesome. I'm doing great. Look at me go Barnesy, pat on my own back. And I was doing nothing because I couldn't get buy-in from my community, which required buy-in from the police, required buy-in from physicians and all the pharmacists. It wasn't until I went to North Bay with Tom Robinson, the police force there, they had a community town hall, and they had, in a small region, buy-in. Once they had buy-in, they showed enough of examples of decreased overdoses due to fentanyl through coroner data that they thought this is a good idea. We need to kind of get that same body of momentum based on, we can always measure how many kits are dispensed, and then we'll have that data to go back to college and saying, government, we got to do something here, right? And that's what's going to happen eventually, but it's just going to take a while to get there.
Yeah, and it would be really interesting to have running statistics on the proportion of opioids dispensed versus the proportion of naloxone kits that are dispensed. Right.
Oh,
and to have that running percentage, I know it's very small.
Minute. And we actually have it. They have data in Ontario of opioid harms per kits dispensed in a region. And what they do know is that if that number is large, there's more kits per opioid harm, then that's a good thing because it means more people are actually getting to the emergency departments. And if you look at Ottawa data right now, because we are such passionate advocates here for the provision of naloxone, and that's across the board, whether it be nurses in doctors' offices and public health propaganda and Mark Barnes and RespectRx and everybody else involved, that because of that, we are seeing more people we have and especially during COVID, high numbers of people making it to emerge and living, and our overdose data is not quite high yet, which is great. So that's what we'll do. We'll keep that going.
Mm-hmm.
Oh, that's wonderful. Well, I really appreciate you talking about the guidelines, and it's I'll also put a link in the details of the podcast so that people can access it. But I was curious, also just about personal stories that you might have with having dispensed naloxone. I'm sure you have some quite amazing stories.
I do. Yeah. I mean,
yes.
So first of all, I mean, I've given out. I can't even tell you. I won't tell you how many naloxone kits. It's just I can't even keep up.
Wow.
I'm just a huge passionate advocate. Personal stories are quite lovely. And during the training seminars that I do, and I've done hundreds, thousands probably, you always catch the stories and they come back at the end to tell you their own personal story about how naloxone saved their loved one, kept them alive. I know from my own personal story that young gentleman in Manitouk was partying with his brothers. If there was naloxone there, he would still be alive. That's my first story, my bad story. The good stories are Ottawa Public Health gets 2 calls per day if someone used naloxone. I did a training seminar, mine are always recent, last week with a supportive housing complex in Ottawa with a maintenance staff who was actually in a high-risk neighborhood. The maintenance staff did my training on a Wednesday. Thursday morning, they rolled into work and there was a gentleman, blue in the face, gurgling, starting to shake in the stairwell. Wow. He remembered it. It's clear as day. Grabbed his naloxone kit that was in his toolbox, and within 30 seconds, the gentleman was breathing again. Called 911, and the best part of this story is that the gentleman came back, the person who was in overdose, and he bought the maintenance staff a coffee. This guy who has very little funds and realized that this guy had saved his life, right? So, I mean, this is the kind of stories you hear all the time. So it's quite interesting.
Yeah, that's unbelievable. Yeah. Well, what a line of work you both are in, and the fight against this, because can be such a tragedy, and the fact that there's something there that can prevent it is, we don't always have.
Even though Ross and I, we're passionate advocates, we're pharmacists, we developed the guidelines. Ross teaches so many people. I do the same thing. We're not the heroes. It's the people who choose to get naloxone and use it are the real people that should be applauded by this.
Absolutely, and that's the point to make. It's not about us. It's about the people that we can empower. Absolutely.
Well, what fantastic conversation this has been, and really inspiring. So thank you both, and I'll definitely provide that link to the guideline, and I'm sure our listeners will be really impressed with this episode and how passionate you both are. So thank you very much.
Thank you.
Thank you.